Good morning. It's been my pleasure to work with Laurel and the Planning Committee on putting this meeting together. And my major role in all of this has been not to get up and speak or whatever, but to put some words on paper. As we thought about what this workshop should encompass, we thought it should focus on providing enhancement of CAB health for children and youth in healthcare settings, and also to focus not only on identification of problems and treatment, but on behavioral health promotion and risk prevention. To that end, we began to look at the literature and actually found that there was no good repository of information actually within disciplines and across disciplines about how this was being done at the present time or how it could be done better in the future. So we took on the job of putting together some thoughts, and there are multiple authors, but do all of you have this paper? And you've been able at least to look at the front page to now, but spend a little time with it. We tried to be comprehensive, but it's not completely comprehensive. It may not be entirely accurate in all places, but I think it is a good starting point. It's a resource, hopefully, not only for this workshop, but for all of us, providing a platform for beginning to think about where we are right now, what our opportunities are and what our challenges are, and how we can deal with those more effectively in the future. There have been several CCAB activities, including a couple of papers outlining the rationale for promotion of CCAB health for children in healthcare settings. And I won't spend a lot of time with this other than to say that, in healthcare, or child healthcare, we have a long history of anticipatory guidance. Now, it's usually in the past been focused to how do you get your kid to sleep better, and what should you feed your child or your infant, and how do you keep your child safe. But there is this history, and in fact, it can become, I think, a focus for helping parents become more nurturing parents, and hopefully we can, in fact, in the pediatric world or family medicine world, begin to help parents bring up their children in a way that's most advantageous to them. And then you also heard earlier this morning that the healthcare setting is really the medical home. It's a place where many children and families of those children with disabling or life-threatening chronic diseases spend a lot of time. And we have an opportunity, in fact, to address their behavioral health, and we don't do that very well. And I'll talk a little bit more about that later. Dr. Buzz Land, spent some time thinking about what the characteristics of a responsive child health care setting would be, a setting that could provide optimal training for students, for residents, for fellows in pediatrics, for psychology training for nurses, et cetera, et cetera. And we've listed 10 here. This compilation is actually contained in a box on page 5 of the manuscript, but it really includes a number of things that I could just quickly point out. Recognizing social determinants of child and family health are important. We've heard over and over again, partnering with families, building on their strengths and understanding them, so in fact we can guide their ability to deal with their individual situations. Fostering parenting skills, not only identifying and treating behavioral health problems, but promoting CCAB health and recognizing and mitigating risks is going to be important kind of attribute of these care settings. Recognizing chronic disease is a CCAB health risk of major proportions. 5% of our population today, and this is hard to believe, but I think it is true, 5% of children in this country have a disabling chronic disease. Disabling means that it really does interfere with their life, with their growth, with their development, et cetera. So this is a big part of the population, and the risks are great for behavioral health problems. These are sites also that need to function as an integrated interprofessional team. And I say team, which means that everybody contributes, everybody helps plan, everybody helps execute or implement. I think this is an important attribute. And then finally, these healthcare settings need to have connectivity with community, and here I include school support services, and having trainees grow up in systems where they understand that you need to reach out and connect and have seamless kind of interaction for families and for children at the community level will be very important. I think that there has been a listing of the various disciplines, and I list some here, and I'm quickly going to go through that, but in pediatrics, the general pediatricians are the ones who do well child care. It's a great opportunity, but the subspecialty pediatricians take care of children and families with major behavioral health needs. There are many parts of the country where there are not pediatricians, and family medicine doctors take care of children and families, and in fact, they have an advantage because they take care of parents and children at the same time. One of the things that's happened in pediatrics historically is we've said we take care of the child, and we can't really deal with family issues or parent issues. That's got to go away. But anyway, we're not there yet. Psychiatry, particularly child and adolescent psychiatry, is a major player. There are some residents who are now training both in pediatrics or family medicine and in psychiatry or child and adolescent psychiatry. If we had more of those people, I think they would be a major asset to what we're trying to do. And then OBGYN was mentioned, but prenatal education programs are an ideal place to introduce parenting skills. And I don't think we're doing that very well. We don't have OBGYN involved in this meeting. I wish we did, and I think we have to reach out to them. Pediatric psychologists, whether they work in primary care or subspecialty care, are really important players. Nurses at various levels of training, and you've heard a lot about this, so I won't spend a lot of time talking about it. Social workers, again, at various levels of training and are important players and part of, the healthcare setting team in almost all settings. And then we heard a lot about parent peer providers and also youth peers, something that our paper didn't address, and I wish it had, but hopefully we'll have a chance to insert that. Overall, what can we make of the status of CCAB health training across disciplines? Well, there are model programs and pathways here and there across the country, but none of them have been disseminated or systematically embedded in healthcare settings, and they need to be. Competence is not a stated expectation of licensing, certification, or program accreditation bodies. This is an opportunity, and you'll hear more about that later. Numbers of individuals who are positioned to promote CCAB health do fall short in all disciplines, and we heard about the mental health workforce, but I would say that numbers of physicians, for example, who are trained to address behavioral health needs of children and families falls woefully short of what we should have in place. There is a big table at the end of the discussion paper, and I'm not going to spend time with it other than to say, and I use pediatrics as an example, we tried to catalog training pathways. We tried to catalog what the behavioral health curriculum guidelines might be in the discipline. By the way, we did this for 8 disciplines. We talk about CCAB competencies and what we know about expectations there, about training program numbers and workforce numbers in each of these areas. So spend a little time with this, but hopefully these data are helpful in terms of being able to focus our attention and our efforts going forward. And then at the end of the paper, we talk a little bit, and you'll hear about maternal and child health programs Models of Highly Integrated Care, the LIN program for developmental and behavioral pediatrics. And I think there are models, but we have to, in fact, understand what works and what can be transported to other areas of the healthcare industry. And then finally, we need to train the workforce in the future to conduct program evaluation outcomes research. And Kimberly Hogewood was nice enough to put together that section. But I think that's an important consideration as we go forward. So, I hope that the discussion paper is helpful. I view it as a platform for thinking about what we are doing now and what we could be doing in the future. I think that as we go through this workshop, hopefully we can extend these considerations and that the workshop report is going to take the next step in elevating our thinking and our recommendations for what might be done. Now, I say recommendations loosely because workshops are not supposed to give recommendations, but anyway, I think we have to imply that this is what we're recommending. And then I hope that this paper will catalyze your thinking about what you can do individually and at your programs at home to further the cause of promoting CCAB health for children. Thank you.